Welcome to this series of interviews with the innovators in cardiothoracic surgery. My name's Joel Dunning and I'm delighted to be here with Atiq Rehman to talk about his work in helping to set up the very first minimally invasive cardiac surgery program in Pakistan. Atiq, you're a surgeon from Sarasota Memorial Hospital in Florida and you're the director of robotic and minimally invasive surgery there. You did a fellowship in 2009 and you've been doing robotic cardiac surgery ever since then. And you've linked up with a hospital in Pakistan that is a large centre. It performs 2,000 operations a year, and just recently you have performed this first minimally invasive operation, so thank you for coming to talk to us. So perhaps before we talk about what you've done over there, maybe just give us a little sort of feel to what you do in your normal practice over here in the USA.
Yeah, as you said, I've been doing minimally invasive cardiac surgery for the last 4 years, and 40% of the cases are done that way, and I do a whole gamut including mini MVRs and robotic assisted coronaries. I've done, I would say, more than 300 of those cases. And over the past 2 years, I've been doing transcatheter valves as well.
Great. So tell us a bit about cardiac surgery in Pakistan. I know really very little of the level of development sort of out there, and also tell us why a country like that might be particularly attracted to a minimally invasive approach.
Yeah, so I think emerging markets, in my opinion, are the growth engines of today. And that, of course, is applicable to healthcare sector and the cardiac services as well. They all have certain challenges, and if you look at Pakistan, of course, the security issues are obvious. But if one were to look beyond that, you see a very vibrant population where they could be at par with any other lead emerging country. So I looked at the cardiac centers as well and picked up the centers which were high volume. There are probably around 10 centers which are doing 1,500 plus cases. And we picked up the largest center, which is the Armed Forces Institute of Cardiology. I went and observed the surgeons, i.e. Afshin, Ali and Amir. And in my opinion, for regular cardiac surgery, their expertise was as good as anyone else. However, of course, they were not exposed to the minimally invasive approaches, and that's where I come in. The main benefits, in my opinion, of course, the same one which are anywhere else, which would be less hospitalization, less blood loss, and of course almost no infection. But then there are particular benefits in a population in the Southeast Asian area, and a couple of them. One is the patients are much younger, so they may be going for second operation for, say, coronary artery bypass surgery or redo mitrals in say 25 years or 20 years. And then if you've done them through a mini thoracotomy, the second operation through a sternotomy will be easier. So that's one big benefit. Second, those younger guys may be the sole bread earners of their households. So keeping them off work for 3 to 4 weeks, I think is not a practical thing. Actually, 2 to 3 months, I would say. So maybe if you do through a right mini thoracotomy, we can get them back to work quicker. And then if in the female population, the younger girls, giving them a midline scar where there's a high tendency of forming exuberant scars or keloids. That's how the South Asian genetics are. I think it becomes a social issue for those girls. So I think it's a practical benefit to them as well.
And there still is a high incidence of rheumatic fever and mitral stenosis over there.
Yeah, I would say 95% of the cases for valvular heart disease is rheumatic.
Yeah, amazing.
Yeah.
So when you decided to go over there and try and bring the approach, what did you have at the top of your mind, and what were you most conscious of that might be the barriers to starting this approach?
Right. I think each emerging market will have unique challenges, but the most common factor, I would say, certainly is the economics of the procedure. So you have to be very cognizant about it. And actually, I would say on this side of the Atlantic now, we are getting more careful about economics as well. So I have tailored the procedure to the extent that the cost of, say, a minimally invasive mitral is not much than the regular sternotomy approach, except probably the femoral venous canal, and of course those are bought in bulk, they could decrease the cost of that as well. And I think to be cognizant about economics is very important to have a sustaining program. You could initiate a program. Any program can just want to have it done to have the first one, but to be able to sustain it, you have to be able to financially sound for that process. You know?
And just for my own knowledge, the model in America is obviously an insurance system, but over there, how do they pay for their surgery mostly?
Yes, so there are some government insurances. For example, the military, of course, if you are entitled, that will be free for you, or some government insurance as well. But the vast majority otherwise will be self-paying. So again, it's a big cost to them.
So the cheaper you make this operation, the better it'll be for them.
Absolutely.
Okay. So your first operation was December 2013. Well done with that. But how did you actually go there and train them, and what are the key implementation steps that you had to do to get them up and running?
Right. So I think it's a multi-tier process. I worked with them for 9 months, and there are key elements. One, you have to train them online. You have to visit them first and train them online, give them some videos. They have to do some simulation. They could use animal hearts. And then the focus remains on team approach, because this is much different than when you're doing a regular sternotomy procedure. There's much more collaboration between the surgeon and the anesthesiologist, the surgeon and the perfusionist. So they have to tailor to that and get used to that part as well. And then once that is done, I urge them, and I urge these guys, and in the future I'll do the same to other programs, that they have to buy the instruments way in advance before the first launch date, so they can get accustomed to them. For example, the knot pusher, they've not used the knot pusher in any other surgery, and there's a learning curve to that, so I think that helps.
Right, so they bought that and they used it in their open mitrals
right,
beforehand. And when you say sort of simulation, I mean, what sort of level of simulation was this? Were they just using animal models for port access, or less? Or was it literally just a heart?
Why, just a heart. No,
so
just a heart.
Yeah,
I mean, there's still
get
heart.
An animal heart and just practice.
Yeah.
So sort of low fidelity. Yeah, that's great. And I suppose what things were expensive, and what perhaps do you use in the US that you don't use there? I mean, are you literally the level of a femoral cannula, a venous one, and everything else normal, or how much have you stripped it down?
Right. So I mean, as you know, the mini mitral, there could be many approaches. You could use a robot. You could use the endo balloon. You could use a retrograde coronary sinus catheter inserted percutaneously. All those have additive costs, and if you can do without it, and which you can, I think that's the way it is. So basically, the way I do it, all the instruments, that's the first upfront cost. But once that is done, the disposables, there's no difference as such except the femoral venous cannula.
So just a chitwood clamp to clamp, no endo balloon. Yeah.
No, either chitwood or the signet clamp. Yeah,
great. And I suppose once you've bought your retractor to retract the left atrium, then that's a fixed cost, isn't it?
That's a fixed cost.
Yeah, that's great. And so I suppose you've gone through this and you've tried this. I mean, what was difficult? What did you find, a difficult thing moving in there, or what was the most troublesome thing, or was it all just in steps?
Yeah, I had gone over with them in steps the different procedure items, but mainly when I was there at the time of launch, there were certain surgical steps like venous cannulation. I thought that's one bottleneck which you have to overcome, and again, because there's coordination between the surgeon and anesthesiologist, and they're not used to that to begin with. So that's one step. And then you go in to identify the right intercostal space. The next will be cross clamping, and then the exposure of the valve itself. So all those steps, you help them, but I think it's a big advantage that you can go actually and scrub with them, which we don't have that kind of liberty here in the United States, or I'm sure in the Western world, because of credentialing issues and licensure issues. And that helps them jumpstart.
Yeah. So how long does it actually take to get a centre independent? I mean, are they independent now, and or how long will it take? Right. How much effort is it going to take out of your life? Poor thing.
So, physical effort, I plan to go there every 6 months. But yes, so we did 8 cases to begin with, and since then they have done mini mitrals and ASDs on their own. They're going to continue doing that. And then we go back in 6 months to review those cases. If they're okay with that, then we move ahead. I think if you pick up the right center, which is high volume, they could get off the ground very quickly. Then because the learning curve is shorter, because it's all volume based, so you do a certain number of cases with them, and they have lined up cases to follow. I think they can get to speed quickly, but 6 months would be a good time at least.
Yeah, so I suppose if they've really got the hang of port access mitral, I suppose a mini AVR is a smaller step because
Yes.
you've already handled the
Yes.
cannulas, and that's next on the list.
Yes, that's the next
Yeah.
list. Yes.
And do you think you'd go towards the mid-cab mini bypass grafting, or is that not such an important thing in Pakistan?
No, it is, and that's. But I kept it as a third tier because I thought let's do the valves first, and once that get them used to the instruments and the small incisions, and then we go to that.
Yeah. So I suppose finally, I imagine some people watching this video will be like, wow, I'd love to go and help countries like this, go and set up programs like this. I mean, how would they go about doing this? Can they collaborate with yourself, or how would you advise people who'd like to do the same?
Yeah, I think collaboration is a good idea, or they could do it independently as well. But a couple of things to be kept in mind. One is that this, as you said, it does take a toll on you because you're doing full-time work. So and you're working in evenings and nights and on vacation time. So I'm lucky that my wife and my kids are supportive of that. But generally, that has to be kept in mind. Secondly, you would need industry support if you're keeping a long sustaining program. It's not a one-time launch. So that has to be there for clinical and logistical support. And then you have to stress upon that you have to identify the right center, because as they say, it's the man in the arena. It's they are down on the ground who have to perform. We can just help them and support them pre-launch, at the time of launch, and post-launch, but they have to perform. So they have to be completely on board, and they have to initiate the process. And lastly, I would say that it has to be completely borne in mind that it is not for marketing purposes. It is for patient care. It's for the benefits which you just mentioned. And there may be a marketing benefit, there may be a good byproduct, but your goal and intention is to provide better patient care for the obvious reasons. And once you have all those goals in line and steps in line, I think you'll have a good, successful program.
Brilliant. Well, it's absolutely fantastic that you've started this, and maybe you'll be the grandfather of many other projects. So very well done from that. And I hope people maybe watching the video, maybe they'll be able to get in contact with you to learn more from you. I'm sure you'd be happy to hear from them. So from myself at CTS Net and everybody here, just thank you very much.
Thank you, Joel. Appreciate it.